My name is Dana Bear. I'm the Director of Advancement at Mental Health America Lakeshore. We're an affiliate of the National Mental Health America located in Plymouth, Wisconsin, and serving Sheboygan County and all the surrounding counties as well. And today we are excited to host a webinar in partnership with Charlie Health on the important topic of navigating youth anxiety and depression, understanding intervention and care. We're honored to have Matino, a seasoned expert in the behavioral health field, and the clinical director for Charlie Health as our presenter. With over 30 years of experience, Anne brings a wealth of knowledge and passion to her work. Her dedication to providing exceptional clinical care is evident in her commitment to supporting and training staff, implementing efficient systems, and utilizing evidence-based compassionate treatment approaches for clients and their families. At Charlie Health, Anne plays a pivotal role in shaping and advancing the mission of the organization, which is dedicated to providing comprehensive treatment programs, including virtual intensive outpatient or IOP, that blends personalized care with peer connection to foster long-term healing. Throughout today's webinar, Anne will guide us through an insightful exploration of youth anxiety and depression, offering valuable insights, interventions, and strategies for care. We're grateful to have her expertise today and look forward to a thought-provoking and informational session. So without further ado, let's dive into this discussion with Anne.
All right. Well, thank you all so much. I appreciate your time today. I wanted just to start by just summarizing a little bit about how we approach care at Charlie Health. I know this is an overall, information on depression and anxiety for youth, but just looking at the fact that, we approach it in a very interesting way. So Charlie Health is just an IOP, meaning we don't do any other type of care like outpatient, general outpatient, just an IOP. And we're really saving lives through providing virtual care for easy access for our clients. So Kala, if you could go on to the next slide, please. There we go. So just to give you a little summary, IOP is three-hour groups a week, and individual therapy and as well as family therapy. And we also have about 30 groups, support groups and skills groups for parents to accompany what we do. And parents can attend our groups during the time when their loved one is in treatment with us and also afterwards. So we know that family involvement is super important with treating kids. So we look at what we call a multivariate treatment mapping when we're trying to figure out the best place for our kids to go, what the best group would be. We look at their condition, like their functional impairments and their diagnosis. We look at their age. We look at what modality would make sense for them. And then we also look at their lived experiences. So we find that this is really greatly contributing to the reduction of their mental health symptoms when they're placed in groups with kids with similar lived experiences, as well as facilitators who have similar lived experiences as the kids themselves. So we have, Charlie Health was started prior to COVID, which surprises a lot of people that we had a virtual IOP, all virtual IOP in mind, even prior to COVID. And we are primary mental health. We do have a substance use component. We are currently seeing adolescents and young adults from about 11 to 34, and we're now in 32 states. And I started with Charlie Health at the very inception, at the inception almost 3 years ago. So we do take commercial insurance and Medicaid, but from what I understand from Kala in Wisconsin, we're not taking Medicaid yet in Wisconsin, but we're planning by Q4 this year to take Medicaid. So that's important to know. Next slide, please. We're going to look a little bit at the numbers in terms of anxiety and depression. And we know, of course, during COVID, they rose and they continue to rise in terms of anxiety, depression, and psychological distress of young people. We're going to look at some of the why that's happening. And then I decided when I was thinking about what might be interesting for you to hear about, not just generally about anxiety and depression, because I'm sure all of you know a lot about that, but looking at kind of the topic of self-diagnosis that's happening now through social media. And then we'll look at behavioral health levels of care and deciding how you pick a level of care that makes sense for clients. Okay, so the next slide, please. So in 2021, as you probably remember, that was the year that the American Academy of Pediatrics decided to say that the youth mental health crisis was a national emergency. Almost 50%, 44% of, so 45,000 students reported symptoms of depression. 37%, so almost 40% of those reported experiencing anxiety, and 15% of students were considering suicide, which was the highest rate in 15 years. So we know it's a lot. I'm not going to throw a lot of numbers at you, but we know it's way too high. And we're very dedicated at Charlie Health, and I know you're dedicated with what you do in reducing, ending suicide and alleviating these symptoms for kids. So next slide. The second, so suicide is the second leading cause of death for people ages 10 to 24. And there was a 25% increase globally in anxiety and depression the first year of the pandemic. That evened out a little bit and then continued to rise. 58% of Americans in this age range of young adults have faced high levels of psychological distress since COVID began. And I wanted to let you know that primarily, the largest population in young adults are women and girls, kids, young people who are in the lower income bracket, who have disabilities, and also in high school, kids who identify with LGBTQIA+ communities. So why is this happening? Next slide, please. So kids are struggling more. A lot of it has to do with the fact that of social media. So it's a curse and a blessing, right? A lot of peer pressure and the fact that kids can bully kids without looking at them in the face or without even seeing them through social media. Bullying is a huge issue, as I'm sure you know. So there's a lot of focus on academic and sports performance pressure for through parents and others. There's trauma from the pandemic that is lasting in terms of isolation and social issues that resulted from COVID. And also, ever increasing screen time. So I'm wondering if any of you want to put in the chat anything else that you can think of. Why do you think teens are struggling more? If there's something that you're thinking of that isn't actually listed on this slide. What have you seen?
Higher divorce rate.
Higher divorce rate, right. What we don't have on this slide is that parents are struggling more. So if parents are struggling more, kids are struggling more as a result of COVID or not. Absolutely. Anything else? Parents and caregivers, maybe disconnected. Climate crisis, anxiety, a lot of things going on in the world, as well as, weather, all that. Yeah, absolutely. So a lot of reasons. So I wanted to move a little bit into the topic of diagnosis through social media and why kids are doing this. So next slide. So 180% is the surge in TikTok use among kids 15 to 25 in the last 3 years. So I just put one example here of views, 6.7 million views of Khloe Kardashian's TikTok post about being OCD because she's lining up cookie jars or whatever it is. So there's lots of examples online of kids and young adults and adults, all of us looking at what diagnosis we may be having. And what we notice at Charlie Health too is sometimes we'll have a rush of kids coming into our program that say they have a certain diagnosis, and we're wondering why that is. And so people within our organization say, well, what's going on TikTok? That's what we say. And DID is one of those, dissociative identity disorder. It's very rare, although a lot of kids are stating that they may have this disorder. And so I just kind of challenge you to think about the times that you may have gone to Google to find out maybe a medical concern and whether it was helpful to you or harmful to you. And why it is that kids are going to social media to figure out what they may be diagnosed with. So celebrities, outspoken clinicians, social media influencers, they've made great strides in destigmatizing mental health. And giving people language and frameworks to help them make sense of what's going on with them. But social media is also full of quizzes and graphs and other things that promote psychiatric diagnoses, sometimes for advocacy and awareness. So sometimes we're looking at true information, and sometimes for profit and for clicks. And so if kids are going online and making a self-diagnosis, the lack of their critical thinking after they do so is really troublesome. And their diagnosis that they find or that they think they have may be correct as well. So there's kind of the good, the bad, and the ugly of it. And so I wanted to talk a little bit, next slide, about how we kind of got to this point. So in the 80s, if any of you were around there, in 1988, a book came out actually called The Courage to Heal. And it started this pop culture fueled phenomenon that vague mental health symptoms could be indicators of repressed memories of sexual abuse. And what happened is it brought talking about sexual abuse to the forefront, which is good, but it also destroyed a lot of families. The Barnum effect, which kind of came next, it was named after the circus showman Phineas Barnum, was a psychological phenomenon where descriptions are vague enough for people to assume they're accurate. And so like horoscopes, that kind of thing, you can relate to someone with a vague description of a diagnosis. And then in the 2010s, that's when we saw content talking about eating disorders and self-harm and suicide on social media like Tumblr and Instagram. But TikTok, with its short video kind of format, has a more powerful impact. And so we've seen a very wide use of social media sites, particularly TikTok, in terms of self-diagnosis. And then moving on to something called psychosomatic role contagion. And that is really went here. Oh, actually, let's go on to the next slide. When kids are really seeking somebody to be like them, and they're wondering where they fit in. And so it's seeking affirmation by kind of diagnosis. And they may actually be masking their feelings of anxiety and depression, but they're seeking affirmation through diagnosis. Next slide. Here's just a couple of examples. So in case studies of self-diagnosis, women who were in this particular study by the Pew Research Study team were saying that they were doing so many duties and they had work outside the home, they're taking care of their kids. And the result were that they were feeling like they had ADHD. So they're diagnosing themselves with ADHD. I don't know if you've heard of this. Next slide, please. Young girls having functional tic-like behaviors. Has anybody experienced this? If you want to throw anything in the chat, where kids are, Tourette syndrome is something that is very unusual, but there was a whole run of kids saying that they had Tourette's, sudden onset, who'd never had any tics before, and we're beginning to self-diagnose with Tourette's. I don't know if you've heard of that. Has anyone heard of that happening? Yeah. Okay. And then next slide is young people, as I spoke about, very rarely are having DID, although it does exist, of course, as a genuine diagnosis. But the media's kind of exploded with people having DID, and young people are identifying this illness as part of their identity, and that makes them feel special. It also gives them an excuse for forgetting their actions. So just a couple of examples of that. So the next slide, what does this mean for the notion that mental illness is stigmatized? So we were at a point for many, many years where mental illness wasn't something that we talked about. Now, because of COVID, people talk about mental health a lot more. It's not unusual for people to say they have a therapist, for example. And so we're looking at a time when we didn't talk about mental health, and now everybody's talking about mental health, and a lot of people are diagnosing themselves. So we want to raise awareness, as you all are well aware, but we also need to look at the self-diagnosis piece. So the next slide, the phenomenon isn't going anywhere. And the slide after that, we still have a responsibility to understand each person's why. So, why are kids or young adults diagnosing? What do they need? What are they hoping for? We have to remember self-determination, and they're trying to find out information, and that can be a positive thing. We still want to educate to the best of our ability and create a safe space, creating trust and rapport, and still delivering excellent care. So I'm wondering so far, what are some of the comments that you have, or any questions about self-diagnosing, or have your experiences been in this area?
I'll chime in. I've seen a lot of teenagers and adolescents stating things, well, two things. One, like, you're triggering me, I'm triggered, or you're traumatizing me, like using those terms very lightly in any moment of like upset, which sort of, I think, diminishes like actual trauma. And then I've seen also, because more mental illnesses and different mental health conditions are being discussed openly, them being used even more as adjectives for things that aren't mental health conditions.
Okay, can you think of some examples?
Like, I'm bipolar when their like mood is fluctuating or they're moody,
Right.
something like that.
Exactly. That's the example I was thinking of too.
Yeah.
Yeah, and so bipolar. Yeah. Okay. Anybody else have experience with this in terms of kids or young adults, or adults identifying with a certain diagnosis? All right, so in terms of social media use, because it's so tied to depression and anxiety in some positive ways and also negative ways, I do have some resources at the end of this slideshow. I don't know, would this be available to folks in terms of resources? Because I have some social media, how to kind of work with social media with youth.
Yeah. Are they like links or research? I can
Yeah,
just
there's some
link them in
links.
the email when I email out the video.
Okay, yeah, that would be great. Awesome. Okay. Okay, so the next slide, really, before we go on to kind of levels of care, talking about kind of a call to action and what can we do in the mental health field about this phenomenon. So I think that talking to our colleagues at conferences, during supervisions and staff meetings is really important. Offering information to the medical and school communities about this too is really important. You know, people are coming into Charlie Health and other organizations, and they're presenting with a diagnosis. And we've never had to in the past say, well, where did you get it from? We just assume that it's a legitimate diagnosis from a mental health professional, but it may not be. So it's something to remember and to talk to medical professionals about too, because people are coming into medical professionals and saying they have a mental health diagnosis that they perhaps diagnosed themselves, and that could be pretty dangerous. Talking about, just getting some more information, of course. And then how do you work with, what are some of the ideas that you would have of how you would work with someone who's self-diagnosed? What are the things that you might do? Either you can speak up or put them in the chat. How would you work with them? Well, I would offer that probably ask how it's affecting their everyday life. Sure. So look at actual functional impairments. So what is going on with them? And I'm not shaming or anything like that. Of course, the fact that they may have found this diagnosis on their own, it may actually be accurate, like I said before too. But educating them through the DSM, finding out more exactly how they're affecting how it's affecting their everyday life. Sure. I'm just doing some education there. Okay, cool. Okay, well, so I'm gonna kind of move on from that topic, but before that, does anyone have any questions about this area? I hope it's relevant to what you're interested in learning about today.
I have a question. Just say like a parent or caregiver's perspective, if your child approaches you and is saying that they're struggling with, or they think that they have the XYZ diagnosis,
Yeah.
what would you suggest as the best first step in addressing that?
Yeah, I mean, I think, there's nothing the matter in Googling stuff. We all Google it all the time, right? And I would say, try to figure out where they can talk with a mental health professional. It may be a school counselor. It doesn't have to be, a therapist in private practice or whatever immediately, but what resources are available in their community for them to get some more information about what's happening. And schools are often pretty good places for that. But then also, any mental health center or, a therapist. Yeah, I mean, we'd want to look at that for sure. And I think, safety, and we'll talk about this when we talk about levels of care, safety is going to be your number one. Is what they're revealing something that that could cause them harm? And so, being honest about asking, hey, are you thinking about suicide? Are you cutting or hurting yourself? Those kinds of questions are really important when young people or anyone is saying that they have some mental health issues or are struggling. And that may indicate, again, what level of care you're getting to next. Cool. All right. Okay, next slide. So I just put something, put a slide in here about complex trauma, but I also wrote on here, somebody told me a long time ago that trauma is anything less than nurturing. I've never ever heard anybody else say it, but I've carried it around with me because people react to trauma very differently. The other day, I used an example of if your house burns down and my house burns down, I may be hospitalized over it and you may be very traumatized, but you can move on with your life. So kids and young adults don't have the same types of reactions to trauma. They're individualized based on a lot of things. And what we're finding at Charlie Health, and what you probably are finding as well, is there's a lot of self-esteem, worthlessness, those kinds of thoughts. So there's behaviors that are coming out of all of that, but what is the basic thought that these kids have of themselves, and what kinds of trauma have they experienced? So the next slide, I'm sure you're familiar with ACEs. And so, it's important to look at adverse childhood and community experiences and how they play a role in what's happening with our youth. And so this is a great slide that just talks about what can be happening in the household, what can be happening in the community, what can be happening in the environment, and to kind of look at what is impacting these kids and why are they behaving the way they are and why are they thinking the thoughts that they're thinking. So I just wanted to make sure to include ACEs in here too. Any questions about ACEs, and have you all used that in your work? Oh, I like this. Another description of trauma. I've heard too much, too fast, too soon. Yeah, very interesting. Okay. I also wanted to mention this next slide here just shows, I love this, this graphic of the heart with the Band-Aids. So young people are experiencing relationship pain, familial, we talked about divorces or other types of issues with families, with friends or in romances. And although we may not sometimes as professionals or maybe even as parents attribute the amount of pain that they're experiencing to what really is happening to them, or think that they shouldn't be experiencing what they are feeling it, and they're feeling it very deeply. And parents and families are feeling feelings very deeply as well. And so there's a lot going on there to try to figure out where those kinds of feelings are coming from and to really acknowledge the pain that's happening in their relationships. The next slide, this is just, I just threw this in here because I just wanted to acknowledge too, when we're talking about depression, anxiety in kids, young people have had issues with individuation for a very long time. So they're growing up, they're trying to find themselves, they're trying to find their identity. And so things that have happened to them that are traumatic can cause some shame and can set them really on fire. And so they're trying to put out the fire by using substances or self-harm, acting out, those kinds of things, to put out their flames. And so just acknowledging, what they're experiencing when we look at depression and anxiety. So can you all tell me some things that you're seeing with youth in your work? Just throw them in the chat. Anything, any concerns, specific concerns, trends, or anything like that that you're seeing? Okay. All right. Let's see. More screen interaction, less face-to-face interaction with peers. Absolutely. Yeah. Speaking of that, you may be interested, fears with post-secondary education. Okay. Yeah, absolutely. A lot of fears around that. And it may seem contrary to think about virtual presentation of behavioral health treatment when we're talking about screen time. So I want to talk a little bit about that too. I'm unsure if a trend, but in our area, I feel like our teens are jumping to suicide quickly. Yes, it's becoming an option, and we need to take it off the table as an option. Yeah. And more people are talking about suicide, which is a good thing. And as you all know, we need to speak about it very directly and ask very directly about suicide and self-harm thoughts. Yeah, absolutely. So getting back to kind of providing online care. So the reason Charlie Health was developed is so that we could reach the most people possible. Charlie was actually someone who lost his life, who was a friend of one of our founders, and lost his life to suicide based on not having resources in his area. And so a lot of people don't really know that, but we're very focused on making sure to make behavioral health accessible. And so, and we've got some great results and outcomes that are on our website. I can speak a little bit to it at the end of our presentation, but so that we know what we're doing is working. So even though we are delivering virtual care, there's a lot of benefits to delivering virtual care as well. Are any of you delivering virtual care? Social media bullying, absolutely. You don't have to see the person. You can bully them all you want. Yeah, using your words to hurt. Yeah, and kids don't know who they are sometimes. And so they're looking at social media and the responses of other peers to define who they are. I was in a supervision yesterday talking with one of my therapists, and I said, this young person, based on what you're telling me, needs to be introduced to themselves. I don't know if I've ever said that before, but as she was presenting what was going on with this case, I was saying, they haven't the faintest idea who they are, and they're gathering all of these pieces of information from wherever they can to define themselves. So we can look at all the behavior, all the all the issues that are coming out of what's happening with them, but really it's based in the fact that they don't know who they are and they've experienced some trauma and hasn't been resolved. And so that's where I would start with that one particular case, but really finding out who they are. All right. So I wanted to go to the next slide, please, and talk about levels of care. That's something that you all had asked us to cover here, or me to cover. And so not sure how much each of you that are on this call actually know about different levels of care. So I'm going to start pretty much being basic about it. So for behavioral health levels of care, we obviously have outpatient therapy once or twice a week, usually for 50 minutes or an hour. There's general outpatient therapy, or there can be therapy that's specifically targeted towards something like trauma, and it might be, for example, EMDR. There's intensive outpatient programming, which is what we provide, which is 9 hours of group, individual, and family. And I am going to say, I didn't check this out first, but I just wanted to let you guys know something that many people don't know. We are actually piloting a whole new level of care called EOP. We call it EOP, Enhanced Outpatient. And this is for kids or young adults that are in our program that are experiencing IOP, and it's too much to go down to once a week after you're in IOP. So they can stay with their same therapist and then cut down on the number of groups that they have. So it's an easier flow to go back to outpatient. And so we're doing a pilot of that level of care with Optum Behavioral Health, and we're really excited about that possibility. But generally, that is not something people know about, or that's a legitimate level of care in other settings. PHP is partial hospitalization. So this is when kids or young adults generally step down, but it can be step in option 2 from hospitalization into a partial program. So they're going all during the day, but going home at night. And then the difference between, we talk about higher level of care sometimes, and there's a distinct difference between inpatient or hospitalization and residential. So hospitalization inpatient, of course, is for stabilization. And it's when kids or young folks are expressing suicidality, homicidality, or they're gravely disabled, which I define as they could do something to hurt themselves or somebody else by accident. And so, or on purpose. And then residential, of course, or wilderness, which is taking them out of the current situation that they're in, their home or whatever, and they're living someplace and getting treatment. Usually that's 30 days. It can be 30, 60, 90 days, 6 months. And so residential is an option too. So does anybody have any questions about this before I kind of dive into levels of care a little bit more? All right, so let's go to the next slide. So when I talk to parents or professionals about levels of care, I'm very clear that there's no right or wrong or failing. That's not the point. The point is, what is the right level of care for what the person needs at the time? And so that's really critical. And of course, safety is the most important thing, looking at if someone is unsafe. And if they are unsafe, hospitalization is usually what we're looking at, or at least to get them to somebody in person who can evaluate whether they need to go into the hospital or not. And, at Charlie Health, even though we're virtual, we do have crisis protocols. We have a crisis team. We call on welfare checks, just like many of you may do in crisis situations. And so we do have a very clear protocol for crises. And sometimes there are kids or young adults that come to us that shouldn't be in virtual care. I'm just going to be very honest about it. They need to be seeing somebody in person for a variety of reasons. And so it's important that you're in a level of care and in a format of care that makes sense for what you need at the time. Insurance will sometimes dictate some things about level of care. Like, for example, they may deny somebody coming to Charlie Health, even though we could really help them because they haven't been to outpatient therapy yet. And so they may say, hey, you need to go to outpatient therapy to see if things can get better at the lowest level of care possible, which does make sense, actually. It's also possible that someone's experiencing something like depression, but they've never had a medication appointment with a psychiatrist to see if that's something that could help them. Medication doesn't help everything all the time, doesn't have to be forever. We're very serious about that. And is what somebody is experiencing something that could be addressed at least temporarily with medication? And so insurances may also say that they need to see a psychiatrist. They need to see if medication will help before we go on to a higher level of care. Also, when we're looking at level of care, we want to look when we're looking at medications. Like I said, if they aren't on the medication and it's possible that they need it, or if they've been prescribed a medication, but they're not compliant with the medication, or if the medication they're on isn't working at all. So those are things that we want to look at as well when we're looking at different types of levels of care. We also usually are looking at a flow rather than skipping levels. So it doesn't usually happen that kids can go from outpatient therapy into residential. So we're kind of looking at flowing from outpatient to maybe IOP, maybe PHP. There may be hospitalizations in there. But one surefire way of understanding that somebody may need a residential level of care, for example, would be if they're continuing to go into the hospital, get stabilized, come out. They're going to their outpatient therapist or IOP. Then they're going to the hospital, they're coming out, they're going to the hospital. So clearly something different is needed. And that would be one indicator of needing, for example, residential. The other thing is that they're not meeting their treatment goals. So whatever level of care they're in, they're not getting better. They're not meeting the goals that they've set for themselves or that their parents or families have in mind, or they're continuing to be unsafe. And so that's another indicator of going to another level of care. So one thing that happens with IOP frequently is people say 9 hours of group and individual, that is a lot. And my kid has dance and they have basketball and they've got this and they've got that. And so I don't know if any of you have run across that in the work that you're doing now, but I never say to parents they need to stop doing that. What I say is, why don't we put a pause on that now so that we can really get this mental health situation under control? Because chances are good that they won't be doing well in school. They won't be doing well at home. They'll continue to have some functional impairments that are really, not working for their lives unless they get the help that they need now. So kind of talking about putting a pause and really investing in a higher level of care if needed. So can you all throw in the chat or talk about anything, any experiences you've had with parents in this way, or have you had those experiences where you're not sure what to tell them about a level of care, or any questions about level of care at all? And I know this is something that you all had asked for me to present. And so I'm wondering, is there something that you were wondering about that I haven't covered in terms of levels of care? Anything that you would like me to speak to more in depth about any levels of care?
I think you covered pretty well, like the levels of care for youth, like what each one is. I think a lot of the times for us at MHA, we have parents often reach out to us that are looking for help for their child, but don't really know where to start. So I think that was a good description of each of those different options. I think sometimes we see too that, insurance is almost always some sort of barrier, because it's like finding the resource that they need that also can be covered by insurance, but also parents ability to get their kids to all of these different appointments. If they're doing IOP, or if they're doing, if it's not virtual, they have to get them to these places, and oftentimes the
Yeah.
parents have a job and they have kids have school. So it is, sometimes it's the logistics that become an issue if it is something more intensive than weekly therapy.
Absolutely. Yeah. Starting off with calling insurance is not a bad idea. I mean, you do normally want to start with the lowest level of care possible. If a kid is struggling with mental health, with substance abuse, has not had any type of treatment at all, you'd usually want to start with an outpatient therapist. And on your insurance card, you should be able to find out who is in your area. You can also go to Psychology Today, and get a good idea of what different folks offer. I always let people know too, parents know, if they're going to talk with a therapist, they should be able to talk with somebody for about 10 minutes, get an idea, does this person sound like they've worked with kids like mine before? Does it seem like this is a good fit? And if it's not a good fit, try to move on. Now, it used to be that insurance company lists of therapists weren't necessarily up to date. So I also tell people to make sure that if they're looking for a therapist, they call several. Sometimes you don't get called back, which is an indicator that that's probably not a great person. If that's, but looking for that outpatient therapist. But there are also things that are happening in homes where kids have not received any kind of treatment, but they really do qualify for IOP. They need more than individually 1 hour a week. And it could involve, obviously thoughts of suicide, severe depression, anxiety, OCD symptoms. There's a lot that they could be experiencing and have not had outpatient, and it may be that IOP is the right level of care for them. But we always want to make sure to have an assessment for that. So hospitalization is always the go-to if someone has a plan and intent for suicide. And if not, but they're pretty severe mental health symptoms, they can always have an assessment, to see what the right level of care is. And that could be at a hospital, or it could be at Charlie Health.
In our area, capacity is a huge issue, which it is in a lot of areas. So we also will, it's like finding the right fit isn't even like an option. Sometimes it's just like, oh, we need to just find somebody that can take someone,
Right.
Which is unfortunate.
Sure. How is psychiatry in your area? Is that easy or difficult to find?
We don't have a lot of psychiatrists in this area. Capacity can be an issue, and it can also be an issue with insurance, because if you're not within like that healthcare system, you can't necessarily go there. And if you don't have a primary doctor within that system, to get into that psychiatrist can be pretty difficult or not possible at all.
Right.
So sometimes we're suggesting, depending on the level of severity, for them to see their primary care doctor, or pediatrician, or using a virtual platform for psychiatry too, if it's,
Right.
more of a urgent, time sensitive need.
Right. Yeah, absolutely. Well, another thing I let folks know is if they call a psychiatrist and the psychiatrist doesn't have room for 3 months, take the appointment.
Mhm.
Don't not take it, because before you know it, the time is, 3 months is up and you didn't, you said no because it was going to be a wait. So that's just another tip. And of course, primary care doctors are getting more savvy about mental health, but it's not their area of expertise usually. And so just like with anything else, if you have heart problems, you're going to go to a cardiologist. Psychiatry is the place to go. And there are some primary care doctors that you just have to use because you don't have any other option, for sure. Yeah, absolutely. Yeah, and so tell me a little bit more about the resources that you have. Are you all on this call in the same area or from all over?
I'm not sure. I recognize some of the names, so I know some of them are in our area, but
Mhm.
I'm not sure about all of them. People could put it in the chat maybe.
Okay. Yeah, if you just want to throw in the chat the area where you live, that would be great. So we can kind of take a peek at that. And then also any questions you have about access to care or levels of care. Any situations that you all have experienced where you're wondering what would be the right next move for this person who came to me, kind of thing. Okay, got it. Okay. All right. Well, we'll have some more time at the end to ask some additional questions. If you want to go to the next slide, that would be great. Connecting the world to life-saving mental health treatment. And then that following slide, virtual care, is how we are battling the mental health crisis. And there's lots of ways that you all are battling them as well. And I appreciate all of your efforts to help folks. I just wanted to skip to the next slide then and talk a little bit about what we're seeing, because we know what we're doing is working, and we know that a lot of things that other people are doing are working too. We need a lot of different avenues to address this issue. So when we look at the young people that are coming to Charlie Health, over 50% of them have moderate or severe anxiety at intake. 57% have admitted to inpatient or residential treatment in their lifetime. Nearly 50% have attempted suicide in their lifetime prior to coming to us. And 7 in 10 had moderate or severe depression in intake. So what we're seeing at the IOP level of care is this kind of a summary somewhat of the kind of acuity that we're seeing in IOP. And that's what we're seeing a lot of in our young people. So throughout our program, we're seeing 89% of our clients reporting improvements in self-harm, 95% improvements in depressive symptoms, 74% are reporting reduction in suicidal ideation, and 92% reporting improvements in anxiety. People are attending the sessions because they're accessible to attend. And the other point that's not on this slide actually is that completing treatment at Charlie Health is preventing 96.5% of clients from readmitting to a higher level of care. And that's what we're looking for here, post-discharge. So this is 6 months after they've been at Charlie Health. And so it's a wonderful level of care. And like I said before, it's neither good nor bad in terms of the level itself, but it's finding the right level of care that's important for folks. And sometimes they have to skip around and they come to Charlie Health, they go to the hospital, or they go to residential, then they come back to us. So that can happen too. So I do have resources, like I mentioned, attached to these slides and at the end. And just wanted to thank you so much for your attention today and see if anyone had any additional questions or thoughts.
I have a question. Earlier in the presentation, you had mentioned that sometimes virtual isn't the right option for certain kids
Yeah.
or adults. What do you have any like specific scenarios where it wouldn't be a good option?
Sure, absolutely. So the one I'm thinking of right now is autism spectrum disorder. So we have a neurodivergent track at Charlie Health. So we see a lot of kids with ASD, a lot of young adults as well. But if you're on the spectrum at a certain point, virtual isn't going to work for you. And so that would be one example. Something like eating issues, if they are a severe eating disorder that somebody needs to see someone about, and that's a primary issue, would be another. Um, in addition, we do have some kids and young adults that have psychosis, but if it's severe enough and it's not, not being treated or not being effectively treated, then that might be something that it wouldn't make sense for somebody to be in groups 9 hours a week, for example, if they were experiencing severe psychosis. So those are just a few examples. I just wanted to introduce Tracy Valentine here. You see her, she's my supervisor on my team. And so thank you for coming, Tracy. Are there some additional examples of that come to mind for you?
I think you have well covered that. Again, people with intellectual disabilities may not be the best fit for a virtual program. And autism, we really love our neurodivergent clients, but you're also, being that it is a spectrum, you're looking at what they're able to do and if they're able to fit well in the group setting. And most of the time it is great, but other times we are not the best fit.
Right. Yeah. Thanks. We've had some kids who legitimately have ADHD to the point where their parents have to like hold them still. That would be something that would be difficult. It also would be difficult because of confidentiality.